Good morning to you all. We are going to start our, in a different way, CME program in a different way today. It's bugs and us. To tell you the background, we receive samples. When you have infections, when you have suspected infections, you send the samples and we do the test and we send a report. Is that all? Is that all we do and what's happening? It's not that simple. So, do all the tests give simple results? Not always, because sometimes we are helpless because we don't have all the facilities to do all the investigations. And with our capacity, we try our best to give some answer to your, to solve your dilemmas in diagnosis. Sometimes we help you, but sometimes we don't. So here are some instances where we could help with the help of others as well. So it was not solely done by us with our limited facilities, but we have done in 3 occasions. So the case discussions will be started by Ruwanthi. Over to you, Ruwanthi.
Thank you, madam. Let's move on to our first case discussion. Our patient is a 23-year-old male from Gampola. He has presented with intermittent low-grade fever that was typically vein and wax type fever, malaise, arthralgia, back pain for 3 weeks duration. His past medical history and past surgical history are not significant. And in social history, he is unmarried and he is a diploma holder in animal husbandry. He has been working in a cattle farm at Ambalanthota for last 1.5 years. On examination, patient was afebrile, well-looking. Blood pressure and pulse rate were in normal range, and other system examination were normal. Initial investigations, we requested full blood count and CRP. CRP was 4.2, we repeated twice, and full blood count, this is his full blood count. Here, there was a WBC count was 4,700, that is in normal range, but towards lower limit. And neutrophil percentage was 43%, that is in normal range, but towards lower limit. And lymphocyte percentage was 47%, that is above normal. And platelet count was 211, that was in normal range, and hemoglobin was normal, 11.8. So, do you need any more details about history, examination, or investigations? Okay. Differential diagnosis were, it was PU, pyrexia of unknown origin, and could be infective endocarditis or any sort of malignancy or collagen vascular disease or any other infection. So there's a history of working in a cattle farm at Ambalanthota. Depending on that information, we suspected brucellosis in this patient. Further inquiry revealed high rate of abortions among pregnant farm cows for last 6 months, and he has noticed similar symptoms in few other farm workers as well. Depending on that suspicion, we requested blood culture for prolonged incubation and Brucella antibody test. This is what we got in his blood culture. After about 2 weeks of incubation, we did the gram stain and we saw gram negative Coccobacilli in his gram stain and blood culture. This is the growth in blood culture plate. His Brucella antibody test report came as positive for Brucella abortus with the titer of 1 to 320. So we managed the patient with initially with antibiotic regime consists of doxycycline and rifampicin. Due to poor tolerability, we changed the antibiotic regime to this alternative regime that consisted with gentamicin 5 mg per kg once daily for 7 days with doxycycline 100 mg 12 hourly for 6 weeks. Okay, our dear sir, Muditha sir will continue the discussion on brucellosis. Over to you, sir.
Thank you, Ruwanthi. Just to add some points on the clinical history, actually this young patient came to me in the private sector. So he was a very clever guy because he was very alert. It was an NLDB farm in Ambalantota. So this problem was going on the cattle farm for nearly 1.5 years. So then he has overheard some of the animal samples were sent to the BRI in Peradeniya, and some of them has become positive for Brucella testing at the BRI. So then he has noticed he himself having this on and off fever going on for nearly 1.5 months. So at that point, with the things happening around the cattle farm, he suspected he might have got this brucellosis. Actually, he came with this augmentation test already done when he came to the private sector. And I had the experience of examining the patient and taking the history. So this was a very classical history of vein and wax type of fever, which is described classical for brucella. That means, I mean, even for typhoid, even for other PUOs, you can get these on and off fevers. But these wax and vein type, I mean, basically, some days you will get sort of a very high grade fevers, but some days you will get very low grade fever. So I think in medicine, probably you might have seen, I have seen some of the OSCEs you will get this moon, I mean the eclipse of the moon. So it is typically, I mean the intensity of the fever changes over the time duration. So these features were there. Then the augmentation test, which was done outside, was highly positive. Highly positive in the sense, if it is 1 in 320, and then what I did was, still the gold standard for the diagnosis of brucellosis is blood culture. So I asked the patient to come to the Kandy hospital, and we took 2 blood cultures, and also with the help of the MRI, I sent again the blood for another type of antibody test. So luckily, within 2 days actually, his blood culture became positive. And when we did the gram staining, it was gram negative Coccobacilli, but it took some time to culture the organism. And meantime, we got these positive results again for the serology from MRI. So it was a confirmed case of brucellosis. Then what I did was I informed the regional epidemiologist of Ambalantota and also the Ministry of Health epidemiology team. They have recently visited this farm, and they found about 7 to 10 patients who were having mild symptoms were positive for Brucella. And I think now they are being treated at Hambantota Hospital. And other important thing is what has happened at the farm was, so this was going on for nearly 1.5 years, but the vet surgeon who was attached to the farm has not taken the proper measures to control the outbreak among the cattle. So that's why it has spread to the spread to several workers, and I think the environment is very contaminated with Brucella bacteria over there. And other problem was where these cattle products like milk and other things has been gone. So I think it is needed to be investigated. Once there is a huge Brucella outbreak in the farm, I don't think these animal products are suitable for consumption of humans. So to talk about on the brucellosis, the Brucella is caused by, as you know, there are several species which can cause, and there are species called Brucella melitensis, Brucella abortus, Brucella suis, and Brucella canis. The Brucella melitensis is caused by goats and sheep, and the Brucella abortus is the common infection among cattle, and suis among pigs, and the canis among dogs. But in the literature, in the textbooks, it says the most virulent one is melitensis, then the Brucella abortus, then suis and canis. And usually, the canis is related to dogs. So we don't know the exact the prevalence of Brucella caused by dogs, but it is, as described earlier, it is well associated with animal husbandry. And the transmission to human, this is a classical zoonotic disease. That means the disease is spread when we get very close contacts with animal, and the human to human transmission is very, very rare. So usually you get the transmissions when you, even in this classical case, this young gentleman had very close contacts with the animal. So definitely they handle animal secretions, animal products, and if the environment get contaminated with a lot of Brucella bacteria, actually through inhalation also, they can get the disease. But once there is a patient in the hospital, you don't need any precautions because human to human transmission is very rare. Actually, the human to human transmission is only with sexual contacts with an active patient. Otherwise, it is very rare. But the most important point here is, if you are on clinical grounds, if you are suspecting a Brucella in the ward, please inform the lab, because when we are handling the samples, I mean, especially the blood cultures, we do some procedures to get them isolated. So there are aerosol generating procedures. Because of that, we have to take a lot of precautions. We have to get the work done in a biosafety cabinet, inside a biosafety cabinet. When we are handling this organism, isolated organism, you have to be very careful. Otherwise, they can acquire through the laboratories as well. And other important thing is, in livestock, to prevent getting the disease, there is a livestock vaccines for cows, and if this is a live vaccine, so immediately after the immunization of cows or cattle, if you are handling their products, even especially milk, through milk, they can get the disease to human. What about the animal products? As I said before, now this farm is contaminated with the Brucella. So what are the chances of getting disease through animal products. So luckily, it is only through unpasteurized milk they can get the disease, because during process, the organism is very heat labile. I mean, the processed cheese or processed milk, you don't have a chance of getting the disease. So this is the transmission cycle. So again, on the clinical presentation, it's a classical PUO, fever, headache, arthralgia, myalgia, fatigue. And the most important thing here is this bug is facultatively intracellular. It can hide inside the cells like TB. So there is a chronic form. This patient actually, we have get the diagnosis because of the awareness of the patient at an acute stage. But if it goes on, this bug can go and affect the heart. It is a classical cause of infective endocarditis, and also it can grow and attack the brain, which is called neurobrucellosis. So in the chronic form, it can affect any organ, but if you can get the diagnosis at the acute stage, the treatment is easy and the duration is also less. So the diagnosis, the gold standard is blood culture, but there are serological tests available even at the private sector. The agglutination test, which is a good one, and MRI free of charge. You can do ELISA test. Both are very sensitive and specific tests. And the culture, and we do have the culture facilities in most of the labs where the microbiologists are there. And the culture is not straightforward, but if you are aware with the prolonged incubation and with the help of the medical laboratory technologists who are aware about the disease, you can isolate the organism with a effort. But that is why the clinical history is very important when you are sending the sample. And as I said before, if you are suspecting a Brucella patient, you need to inform us, because we need to take some precautions when we are handling the samples. So, confirmed brucellosis, what are the treatment options? We need to start the treatment immediately to prevent the chronic infections and also getting endocarditis or neurobrucellosis. I have to mention one thing here in the clinical presentation. Even in the literature, it says the sacroiliitis is one of the common presentations. Actually, apart from these the culture positive confirmed cases, I have seen some few cases in the orthopedic wards. We confirmed them through the serology with sacroiliitis. So here, this is a classical example of a Brucella outbreak. But sometimes, actually in Sri Lanka, we don't know the real incidence of Brucella, because I mean the cats, sometimes pigs, even goats. If you go for state sector, this animal husbandry is not very uncommon. So I don't think, with my clinical experience, this is a very rare disease in Sri Lanka, because we don't diagnose them adequately to see the true incidence of the disease. So even for physicians, if a patient comes with on and off fever with some sort of a sacroiliitis, you have to suspect brucellosis as one of your DDs. And as our SR shown to you, sometimes this blood picture, sometimes these the full blood count, you have clearly seen the lymphocyte count is high compared to the neutrophil. So these are some of the clues where you can think brucellosis if a patient comes with PUO. So the treatment, there are many treatment options, but the most important thing is, even acute mild case, the patient needs long-term antibiotics. So there are different regimes. We used to treat with doxycycline and rifampicin for this patient, and also 7 days of gentamicin. And then you have to put the patient on doxycycline and rifampicin for 6 weeks. But if the patient is having arthritis, or if it is infective endocarditis, or the neurobrucellosis, the treatment duration is long. Sometimes you have to treat them for 6 months. There are several regimes. You can use Cotrim, you can use, as I said, doxycycline. And if the patient is having neurobrucellosis, you have to combine this antibiotic with ceftriaxone also. So that is about brucellosis. As I said before, you have to think if a patient coming with PUO, one of the DDs should be brucellosis. But like this case, if this is pretty obvious, he's a worker from a farm, so definitely the brucellosis is high on the list. Sometimes you can't get the real exposure. So in these cases also, even down on the list, you have to think about brucellosis if the patient is having PO. And the most important feature is at the acute stage, the patient is not very ill. So the second clinical case, I will do the clinical presentation as I have managed this patient, and the case, the discussion will be done by my senior registrar. So the second case, this is a 37-year-old male from Jaffna, a welder by profession, and due to CKD, he has undergone kidney transplantation 2023, and as usual, patient is on immunosuppressions, that is MMF and tacrolimus. And patient admitted to Kandy Hospital with shortness of breath, body swelling, fever, pleuritic type chest pain for 4 days. On examination, the patient was ill-looking, febrile, dyspneic, pale, and had generalized edema. These were the cardiovascular findings and the respiratory findings and the abdominal findings, and the CNS is GCS was okay. And these were the investigation findings. The CRP was elevated, but it was hanging above 100 most of the time. White cell count is, it is towards normal, but he has stayed in the hospital for nearly 1.5 months. So initially the eosinophilic count was normal, then it was slightly elevated. So on one admission, at first episode, patient was in the ICU, then sent to the ward, and then again his respiratory functions deteriorated, and again patient was taken back to the ICU. So then after about 30 days, I think, this patient deteriorated. We use a lot of antibiotics during the management, and prior to this admission, the nephrology team thought his kidneys being rejected, and several times he got the dialysis also. So as usual, the patient had SOB, we thought of a pneumonia, and as a result, we did these usual routines, that is influenza PCR, COVID PCR, and the patients who are on immunosuppression, especially renal transplant patients, they can get disseminated cytomegaloviral infection. So the cytomegalovirus PCR was done on blood, and as usual, we didn't have any clue. As a result, the patient was given a broad spectrum antibiotic and antivirus for many days. The blood culture no growth, urine culture no growth, sputum culture no pathogen isolated, influenza PCR was negative, and the cytomegalovirus DNA was positive, and as the patient was immunosuppressed, we start on valganciclovir. And at that time, this is the second admission to the ICU, day 8, patient developed diarrhea. So as usual, we thought it was antibiotic associated, and C. difficile is the one which can cause these sort of severe infections. Then we decided to add oral vancomycin also to this patient. But patient was not improving. And then when I did the routine rounds, the cryptosporidiosis also which can cause diarrhea in immunosuppressions. So the cryptosporidiosis is diagnosed by doing AFB testing as a sort of a kind of a modified acid pass staining on the stool sample. So I send the samples to our lab to get done the cryptosporidiosis test. And also at that time, the patient's eosinophilic count was on the higher side. So it is usually when the eosinophilic count is on the higher side, in automated full blood count, it is better to call the hematologist and send a sample to get done the manual blood picture, manual counting. Then you will get a true picture about how much of eosinophils you is having. So what do you think the diagnosis? So the patient was a renal transplant patient in the hospital for 1.5 years, coming with SOB. The later stage of the disease had a high eosinophilic and patient developed a diarrhea. Patient was on many antibiotics and respiratory wise, patient was deteriorating, and you have seen the second chest X-ray. One lung was totally gone. So luckily, we will acknowledge the MLT team who are in our hospital. That's why even at the introduction, Madhumanee said, even with the minimal facilities, sometimes if you are clever enough or if you are very enthusiastic on the diagnosis, sometimes we do get diagnosis even accidentally. So when I was doing the bench round, my colleague MLT has shown this slide from the stool sample which was sent for AFP. So any guesses, any parasite? So this was a strongyloides, which is called threadworm. So he has seen live larvae in the stools actually of this patient. Even the microbiology team at that time never thought about this is a disseminated strongyloides case. Then I got a call from the hematology lab from Dr. Sunetra telling, so I sent the blood to see the eosinophils, but she just gave me a call and said she has seen some larvae in the blood. So then we sent the stool sample for Peradeniya Parasitology department, and it was confirmed. And the gold standard of diagnosing this test, this organism is culture. Unfortunately, they couldn't grow it. So you can see on this last slide, this is from the blood. So it was a classical case of disseminated strongyloides. So it has gone all over the body. So then immediately we started on ivermectin, but unfortunately, we were very late on the diagnosis. And I think though it is mentioned at the same day, 2 days later, the patient succumbed. And my SR will discuss the disease strongyloides, but here the most important point is for the nephrology team, how frequently are we using anti-worm treatment on these immunosuppression patients? Because even from albendazole, you can treat. If an immunocompetent patient gets the disease, single shot of albendazole will help to eradicate the bug. I think here the take-home message would be, we have to think seriously on renal transplant patients. We know that we are very closely monitoring cytomegalovirus DNA copies in the blood of immunosuppression patients. I think what we can do here, the renal transplant patients or immunosuppression patients need regular anti-worm treatment, because once you get the disease, it is very, very difficult to eradicate. This is my feeling is we should start. We will have to find some protocols, and we should start the regular anti-burn treatment on immunosuppression patients. Thank you, and over to you, Ruwanthi.
I'm going to discuss about strongyloides, hyperinfection, and disseminated infection. This is the disease process when the individual's immunity is impaired, that means due to organ transplant or due to corticosteroids, auto-infection is accelerated. Then high number of migrating larvae can be seen in the his blood. Then it can cause hyperinfection. In hyperinfection, larvae are limited to GI tract and lungs. But if we didn't attend at that time, it can go into other internal organs as well, such as brain. That is called disseminated infection. This is the life cycle of Strongyloides stercoralis. Actually, it is a complex life cycle compared to other intestinal helminths. It has a free living cycle as well. Without entering human body, larvae can live in the environment if the environmental conditions are satisfactory. And it can cause auto-infection. That means without soil transmission, it can auto-infect the same individual again and again. That is the importance of knowing Strongyloides stercoralis life cycle when managing patients. Clinical features. In the GI tract, it can cause abdominal pain, vomiting, diarrhea, abdominal distension, paralytic ileus, and necrotizing jejunitis as well. In lungs, it can cause hypereosinophilia, pneumonitis, pleural effusion, and sometimes pulmonary abscesses. In disseminated infection, there can be neurological complications like convulsions, meningitis, and focal neurological signs. And it can cause sepsis with enteric organisms. This is because when larvae migrates from the gut to bloodstream, it can carry gut organisms, gut bacteria over its surface. Then when the larvae enters the bloodstream, that gut bacteria can cause sepsis and septic shock. Diagnosis, stool wet mount, and there are concentration methods as well. And in hyperinfection and disseminated infection, we can see larvae in the sputum as well. There are several culture types available to cultivate Strongyloides stercoralis, Harada mori filter paper technique, stool culture on charcoal, and agar plate culture. Enterostring test, this can be used to detect larvae in duodenal fluid. Management, first line treatment is ivermectin 200 microgram daily for 2 days. In disseminated infection, we can continue this for even 14 days. Alternatively, albendazole 400 milligram 12 hourly for 1 week can be used. If left untreated, mortality rate of hyperinfection or disseminated infection can approach nearly 90%. So that's the end of our second case. Let's move on to third case discussion. Here, our patient is 4-year-old boy. He has presented with 5 days history of cough and 3 days history of high-grade fever. Upon admission, mother has noticed a small pustule, purulent nodule on his right arm, along with erythematous swelling on both lower limbs. This is the purulent, you can see, purulent nodule in arm and erythematous macule on lower limbs. His past medical history and past surgical history are unremarkable, and immunization is up to date, growth and development age appropriate. On examination, the child was ill-looking and febrile, tachypneic, and there were crepitations in right side of the chest. Child was tachycardic but hemodynamically stable. Other system examination were unremarkable. So these are the investigation's findings. Initial WBC was 16,000 and at day 5 it has gone up to 45,000 and there was neutrophilic predominance. Blood picture indicates severe bacterial infection and CRP was initial one 342. Chest X-ray, there was consolidation in right lower lobe. So at the ward, child was started on intravenous coamoxiclave, but there was no clinical improvement after 48 hours of antibiotics. Then blood culture and swab culture from that purulent lesion were taken. What may be the diagnosis? Is it MRSA infection? Okay. Blood culture flagged positive in 9 hours of incubation and it was gram stain short, gram negative bacilli. This is the blood culture isolate on blood agar plate and this is the ABST McConkey agar growth. You can see the characteristic bluish green pigment. So what is the diagnosis? Any guesses? Pseudomonas. Culture isolate was identified as Pseudomonas aeruginosa and swab culture from that purulent lesion indicated the same organism with similar ABST pattern. So depending on the ABST, we changed the antibiotic into piperacillin tazobactam and child's condition improved. He was discharged after 14 days of antibiotics and planned to review in the pediatric clinic. So this is a patient with Pseudomonas aeruginosa bloodstream infection with ecthyma gangrenosum. I will invite our dear madam to continue with discussion of this Pseudomonas aeruginosa bloodstream infection. Over to you, madam.
Thank you. So we hardly get Pseudomonas aeruginosa bloodstream infection in otherwise kind of like walking patient, because if we get Pseudomonas aeruginosa in the blood culture, either patient is already dead or kind of dying in the ICU. So this was very odd actually. We initially what we thought whether it's one thing, whether it is a contamination, because Pseudomonas can be in any water thing like solutions, whatever you sometimes you use for cleaning before the blood culture. But the thing was the both blood culture and the wound swab culture grew Pseudomonas aeruginosa. And again, we thought whether it is Pseudomonas Abeywardena, which can cause lumps, abscesses on the skin and chest infection and bacteremia, so everything. But it was a typical Pseudomonas with green color on ABST plate and sensitive pattern, very sensitive thing. And so that we have discussed with Dr. Abeywardena about the patient's condition, because how can it be, because child was smiling and he was not too bad. Then of course whether our worry whether the child is with any immunocompromission, and for which Dr. Abeywardena started investigations because the child had one episode of hospital admission about a year ago, I think, as I remember, but it was not significant, like nothing was serious. About its Pseudomonas, as we know that it's a ubiquitous organism commonly encountered in various environmental samples, including soil, water, can cause infection, especially in ICU patients or sometimes in patients with stent, stones in the urine tract, sort of, not in a otherwise healthy child. So, coming to acquired Pseudomonas aeruginosa bloodstream infection, rare. Ecthyma gangrenosum is characteristic skin manifestation. But again, with ecthyma, the patients are dying. Normally, they are dying. Even with the antibiotics, they won't survive. So that sort of ecthyma the child had. But as we suspected MRSA, when we get skin lesions, most of the time we suspect Staph aureus infection. But the little difference is there because in Staph aureus, the lesions are a little more angry looking, red, painful, and tender. So here the lumps were not painful as well. So the pediatric ward, Dr. Ruwanthi Ranaweera has started anti-pseudomonal antibiotic for sufficient duration, 2 weeks continued, and child got better. And investigation for congenital and acquired immunocompromission status were looked at that stage. So child was referred to an immunologist by the pediatrician, and following which the child was diagnosed with immunosuppression XLA. I just got it, XLA, but which is not confirmed. So what we want to convey, having a positive culture and treatment will not solve the problem. It might open a new avenue for some investigations and more treatment and sort of. So that's all our cases, and we acknowledge Dr. Sujatha Patarage for the first case, Dr. Sunetha Tauda for the second case, Department of Parasitology, Dr. Ruwanthi Ranaweera, Dr. Danushka Dasanayaka, consultant immunologist MRI, nephrology team, medical team, and Mr. Samaravira of MLT, who was very, very talented and who helps us a lot in diagnosis. Thank you.